Problems with neurologic function. Unit objectives: apply the core knowledge of normal anatomy and physiology to the management of patients with acute alterations in neurological function. Apply physical assessment and diagnostic tests to the management of patients with neurological disorders. Apply knowledge of the pathophysiology of brain and spinal cord tumors to the management of patients with tumors. Apply knowledge of the signs and symptoms of increased intracranial pressure to the management of patients with neurologic disorders. Apply the knowledge of nursing implications and complications to the management of patients with head injuries. Apply the knowledge of nursing implications and complications to the management of patients with spinal cord injuries. Identify causes, signs and symptoms, and treatments for patients with seizure disorders. Differentiate between various infectious, degenerative, autoimmune, and other neurologic disorders. Apply concepts of incidence, risk factors, pathophysiology, complications, and treatments to the management of patients with strokes, and describe the causes, treatments, and rehabilitation of patients with upper and lower back pain. So we're going to do just a little bit of an A&P review and talk a little bit about assessment. So you have two types of neurons. You have motor neurons and sensory neurons. So sometimes the neurological conditions that our patients have are problems with the different types of neurons. Some conditions will impact motor neurons, some will impact sensory, some will do both. Nerve impulse conduction. Now we remember that nerve impulses are electrical impulses that jump from neuron to neuron across the synapses, and in those synapses are neurotransmitters, chemicals that can either speed up or slow down that nerve impulse conduction. So there are some conditions that will impact the speed or the ability of those impulses to go from neuron to neuron. We have our cerebral circulation, and sometimes there can be problems with that. Certain occlusions, just like we talked about coronary artery disease, we can have cerebral arterial problems with occlusions, narrowing, atherosclerosis, arteriosclerosis in our cerebral circulation. We can also have malformations, congenital malformations in that circle of Willis at the base of the brain. And then we have our autonomic nervous system, our sympathetic and our parasympathetic. So we talk about the sympathetic, the fight or flight, which increases our heart rate, increases our respiratory rate, causes vasoconstriction to increase our blood pressure, and slows down our GI motility. Then we have the parasympathetic, which sometimes you can hear it referred to as rest and digest. So that's when everything kind of goes back to normal, and it counteracts those impulses from the sympathetic nerve system that can just keep going and going and going until we just kind of go crazy. Now, our elements of the neurologic assessment, and this is very, very important that our baseline assessment data is well documented, well analyzed, because even the slightest changes in neurological condition can indicate a deterioration that we can nip it in the bud if we identify it, because someone has documented their baseline very, very accurately. So remember that you always have to do that baseline assessment of these various neurological assessments that we're doing, that I'll be talking about, and those have to be documented very, very carefully. When we talk about cranial nerves, you learn those in anatomy and physiology. I don't know how the NCLEX will ask you those. Will they give the number? Will they give the name? On my exams and on ATI, they give you both. So I'm assuming that probably they're going to do that on the NCLEX. But make sure, at least by the NCLEX, that you know both, the number and the name, and learn the types of situations that these cranial nerves can impact and how we assess them. There's a couple of cranial nerve diseases that like to come up on the NCLEX. One of them is trigeminal neuralgia, an inflammation of cranial nerve 5. And what's causing it is irritation of nerve fibers, traumas to the jaw, the teeth, the ear, infections, that sort of things. And the pain can be excruciating. Some of the treatments that we give these patients are anti-epileptic drugs such as gabapentin, Neurontin, which is helpful with neuropathic pain, Tegretol, Dilantin, various antispasmodics. Sometimes patients will have phenol or alcohol injected into the nerve to numb it, or they can have surgical decompression of that nerve. It is very, very painful. Another one is something called facial paralysis or Bell's palsy, which is a paralysis of cranial nerve 7. And that can be also caused by things like infections, colds, herpes simplex virus. And so our treatments can sometimes be antiviral medications, steroids like prednisone, analgesics, a facial sling to hold that side of the face up so that the eyelid doesn't droop and they're able to actually close their eye. Some patients, after this has resolved, will continue having residual weakness or neurologic deficits. Now, your Glasgow Coma Scale. I will be testing you on this. You will need to know the 3 broad categories, but I'm not going to ask you what the different line items are underneath each category. So motor response, how they respond to painful stimuli. Verbal response, do they respond accurately? Are they alert and oriented, or are they confused or even comatose? Eye-opening points, do they open their eyes spontaneously, or do they only open their eyes or respond to painful stimuli? So again, you do need to know those 3 broad categories of the Glasgow Coma Scale, but I'm not going to test you on what individual point values are given to those subcategories. Now, some of our diagnostic tests, CAT scans you're very familiar with, they can detect the structure of the central nervous system, the bone, the soft tissue, if there's blood or excess CSF. They can identify tumors, abscesses, that sort of thing. You may or may not use contrast dye, depending on what is needed. And afterwards, if they have a dye, we're going to be pushing fluids. Now, a PET scan, which will also be referred to as a brain scan in some situations, this is where you have a radioactive isotope that's absorbed into the brain tissue, and it detects metabolic alterations. So it tells you how well your cells are metabolizing. So we are going to, prior to a PET scan, keep the patient NPO, no caffeine, no stimulant, or depressant types of drugs. We don't want to abnormally change the metabolic activity of our brain cells. The SPECT, single photon emission computed tomography, is also a radioactive and nuclear medicine test, and what that does is looks at perfusion. So it tells us how well the brain is perfusing. MRIs are where we are using magnets instead of ionizing radiation, so it is safer for those patients. It doesn't give them exposure to radioactivity. However, there might be certain implants or arthroscopic types of situations where patients would not be able to have an MRI because what they have implanted in them is magnetic. Cerebral angiograms, and just think of when we talked about pulmonary angiograms, coronary angiograms, and now cerebral. Same pre-procedure questions and concerns, same post-procedure positioning and potential complications. Now, a myelogram is a water-based dye that is injected via a lumbar puncture. And what this does is it goes into the spinal and subarachnoid areas, and it tells whether or not we have any bulging discs or any misalignment of the spinal column. So patients are often NPO prior to a myelogram. They're on bed rest, head of the bed is elevated, and we're pushing fluids to flush that water-based dye out of them. An EEG is an electroencephalograph, and that records the electrical activity of the brain, just like an EKG does for your heart. It can tell where seizures are originating from. It can tell how our brain is functioning. So oftentimes the EEG is used to detect brain death if they don't do a brain scan, a PET scan for that. Electromyography, that and EMG, that tests peripheral nerve function, where they're basically zapping your peripheral nerves to see how they respond. So this can be done sometimes prior to a person having carpal tunnel surgery, or to diagnose certain neurological conditions that patients are presenting with to determine if it is a central nervous system disorder or a peripheral nerve disorder. And then lumbar puncture, which the NCLEX loves to ask about. It's in the subarachnoid area. A needle is injected between the third and fourth, or fourth and fifth lumbar vertebrae. The reason we do it at that particular point is that it avoids the end of the spinal cord. It prevents us from accidentally hitting the spinal cord with that lumbar needle. We use it to remove samples of CSF for testing. We can use it to diagnose various infectious diseases. We can use it to inject contrast mediums, for example, with the myelogram for diagnostic testing, to go do spinal anesthesia, to, under controlled conditions, reduce elevated intracranial pressure by releasing the excess CSF that the patient has accumulated. After the lumbar puncture, patients need to lie flat based on how long that the physician has ordered that, and we're going to be pushing fluids to replenish the CSF that they have lost through this particular procedure, because that will help to prevent a spinal headache, which can be very, very uncomfortable, very, very painful. Other complications of lumbar punctures could be infections, could be CSF leaks. So if you see a clear fluid leaking from that puncture site, that means that the meninge did not seal over when we removed the needle. And now we're leaking CSF out that needle hole. And also bacteria could get in. So when we see that, we're looking for a halo sign on a dressing. So a little pinpoint maybe of blood, and then surrounded by clear or yellowish fluid. Or we can test it with a glucose urine dipstick to test for the presence of glucose, because if it's just serous drainage, then it's not going to test positive for sugar. If that patient has a CSF leak, then we can do what's called a blood patch, where we take a sample of the patient's blood, the doctor goes in there and puts that blood over that hole in the meninge, and it will clot and seal off that hole so we don't have the CSF leak anymore. The last two things on this video we're going to talk about are brain tumors and spinal cord tumors. You are not going to be responsible for saying, oh, this particular type of tumor is malignant, this one is benign. We have to be very aware of the fact that any brain tumor, malignant or benign, is going to cause problems, because any kind of tumor expands and it invades and it infiltrates and it displaces the normal tissue, leading to edema, inflammation, increased intracranial pressure, and pituitary dysfunctions. So regardless, they have to come out. They have to be treated, they have to be shrunk if we can't surgically remove them, regardless of whether they're benign or malignant. We can have primary brain tumors that are originating within the brain, or secondary, which have metastasized from tumors or cancers elsewhere in the body. The specific signs and symptoms are related to the area that's affected, and you're not going to be tested on that. You're not going to be asked, if the patient has a temporal lobe tumor, what are the signs and symptoms? What neurologic deficits will they have? That's not expected knowledge for you as entry-level nurses. The management of brain tumors, we're going to do radiation. We can do it by itself. We can do it in combination with chemotherapy. We can do it before and after surgery, before surgery to shrink a tumor, after surgery to remove any potential lingering cancer cells. Chemotherapy, and we do that through what they call the intrathecal, intrathecal, and that means that we put a catheter into where the tumor is and deliver the chemo directly to the tumor, because we have to bypass the blood-brain barrier. So the intrathecal route is very commonly used. Other pharmacology when patients have brain tumors: steroids to reduce inflammation, anti-epileptic drugs to prevent seizures. We don't want a lot of extra electrical activity going on in the brain when we've got other problems going on. Preventing stress ulcers, preventing nausea and vomiting, because sometimes the brain tumors can impact those parts of the brain. And then we can do surgery. And I'm going to play this awake craniotomy video in class, and we're going to talk about what the post-op care would be, how we would be positioning patients and that sort of thing, and what our complications might be after a craniotomy. So stay tuned for the class. Spinal tumors, we're going to look at those the same way we did at brain tumors. They can be primary or secondary, metastatic, and the signs and symptoms, the neurologic deficits, are going to be related to what area of the spinal cord or what spinal nerves are being involved and being impacted. Surgical management would be to either remove or decrease, debulk, what they call debulk, reduce the size of the tumor, to help relieve pain and manage symptoms. And then we can have non-surgical management of radiation. Limited chemo doesn't really have a lot of good effect on spinal tumors, and doing things for pain control.